we have got different ways by estimating the region of almost abnormality. We will be able to do the wall motion scoring. Now, let us look at the left ventricular function evaluation. In the left ventricular ejection fraction, we can estimate normally people normally are not doing it. Just do the M mode. That is why many times the ejection fraction estimate on echocardiography is not reflective. But ideally, and what we do normally is to measure the left ventricular function in two projections. So biplane means you take a two-chamber view and a four-chamber view, so that you are able to represent in this view certain walls are represented, in this view certain segments are represented. So if we take these two projections, we can represent almost a majority of the 17 segments. So that's why we take two projections, and using a biplane, Simpson's biplane method, we can estimate the ejection fraction. Apart from that, if you can see, we can estimate the end diastolic volume and systolic volume in both two-chamber, four-chamber, how much is the left ventricular length and how much is the left ventricular area. So this is a very beautiful way on two-dimensional echocardiography to estimate the left ventricular function. So this is a common method what anyone should do. So for example, if you got a discrepancy with the echo report with any of the places, you can always request your cardiologist to do a Simpson's biplane method, which is there in standard in all echo machines. Now, beyond this two-dimensional method, what nowadays we are doing almost routinely is doing a 3D echocardiography. Why we do a 3D echocardiography is because it has got a better reproducibility. So sometimes you get a EF of 35% by one doctor, another doctor might give 42%. So you get confused whether 35 is right or 42 is right, because the problem might not be with the physicians, it is based upon the two-dimensional method. You will not get the same reproducibility. But when we do a 3D echo, you will be able to give a clear-cut, accurate reading, and it has got a better reproducibility. Along with that, if we do a contrast agent, like I have shown you in the previous picture, if you use a contrast agent, what happens is the contrast opacifies the ventricular cavity, so you can see the endocardial border so nicely. So contrast echo, 3D echo, and Simpson's biplane, these are the various ways in which we can estimate the global left ventricular function. But if you go back into this picture, you have got the 17 segments, and each segment has got a different number. So here you can estimate the regional ventricular function. So this is a global ventricular function, whereas in the GLS you can estimate the regional ventricular function. So for example, how much is the reperfusion and whether we did good or not. So we will be able to see. Now you can see here. Hello, sir. Yeah. You can see here, you can see this is the GLS 17 segment. You have got multiple dotted lines with various colors. Each of these lines represents one segment. So you can see when the machine reconstructs the 3D image, you can say that each of these segments is represented in this model. So 3D echocardiography is a better reproducible way. Similarly, you can see here, by giving contrast agent, we can see that the endocardial border is nicely defined, whereas such a definition might not be there for many times for a lot of patients. Now, so when we are, as I told you, if you see the heart contracts, the heart can contract like this, will contract like this, and apart from that, this is the circumferential contraction. Ejection fraction estimates the circumferential contraction, but the most of the contraction of the heart happens in the longitudinal plane. So from the apex to the base of the heart, it squeezes the blood, and it has got a torsion also. It squeezes from apex to base, and it circumferentially contracts, and it squeezes also. So the GLS takes into the longitudinal contraction as well as the torsion of the ventricle. So that is why this strain analysis has become a very important tool for us in various scenarios. valvular heart disease. Normally, by the time the ventricular dysfunction sets in, like let us say if a person comes to us with an ejection fraction of 45%, normal ejection fraction is 53% or 54% based upon the gender. But if the ejection fraction is 45%, then what is happening? By the time the EF reduces from 53 to 45, the GLS falls from 17 to almost 11. So the GLS is a very sensitive, that means a very early marker for left ventricular dysfunction onset. So this is an important parameter which one should incorporate into their daily diagnostic evaluation. Apart from that, for example, a person has got a stable angina, not an unstable patient, but if the patient has got a stable angina, even in the stable angina patient also, if there is a GLS which is higher, that means if the normal is minus 17 and the current GLS is minus 10, that means minus 17 to minus 10 is a larger number. So if it is there, then it is usually a higher GLS indicates a poorer outcome. So advanced strain analysis is a very important thing. It is more sensitive than ejection fraction. And very importantly, for example, if the person has got an obstructive coronary artery disease and there is a myocardial damage, then only the ejection fraction would be able to pick up the ventricular dysfunction. But the GLS will be able to detect even non-obstructive coronary artery disease also. So it has got a superior sensitive as well as a superior prognostic value. Now let us look at a couple of images of ischemic dilated cardiomyopathy. That means there is a coronary hypoperfusion. Whereas non-ischemic dilated cardiomyopathy, where the coronary perfusion is normal. If you have seen the previous GLS, the color is completely different. You can see a bright red color. But when you go to the next image, you can see that it is hypoperfused. There is no red at all. This blue means it's a very, very low perfusion, and some degree of light pink is there. It is not even minus, but it is a plus 4.6. So as I told you, normal GLS is minus 17, minus 18, but here it is plus 4.6 means the ventricle is grossly hypoperfused and there is no blood supply to the ventricle. So this is a ischemic dilated cardiomyopathy. Whereas on the other hand, if you look at the non-ischemic dilated cardiomyopathy, you can see there is some degree of brighter pink with a lot of hypoperfused or damaged area. So based upon the GLS pattern, you can differentiate an ischemic, that is coronary hypoperfusion, the one without coronary hypoperfusion. Now, we have understood about 3D echo, we have understood about global longitudinal strain, we have also understood about circumferential ventricular function by using the Simpson's biplane method. Now let's go on to the stress echocardiography. Stress echocardiography for detection of ischemia. So this stress echocardiography can be done on the stress test or can be done with a dog-between stress echo. But majority of the time in our country, in our geography, we do a pharmacological stress test. But when you go to the Western countries, especially to the US, they do a bicycle ergometer and do a stress echocardiography with a bicycle rather than a medication. The advantage of stress echocardiography is with an ECG stress with an exercise versus a drug stress test. Both have got similar sensitivity and has got stress echocardiography has got a similar specificity like nuclear imaging. And for example, we do a stress echocardiography and say that the stress echo is normal. That means the annual cardiac event rate is very, very low. The advantage of echo is obviously no radiation, as I told you. And apart from the left ventricle, we can look at the walls, we can look at the right ventricle, we can assess the filling pressures, which are not possible with the other modalities like CT or MRI. Now let's go on to the dobutamine stress echo. So instead of the previous level, we have considered a echo on the stress with a treadmill, that is exercise stress. Now we are going to a pharmacological stress. In the pharmacological stress, we have got a different protocols. We go incremental doses of dobutamine And as we go forward, the ventricle gets contracted more and more. Now, if you can focus here, this is an artifact, but you can focus here that the ventricle cavity is completely obliterated on the dobutamine stress echo. That means it is like this, fully obliterating the ventricular cavity. If, for example, the ventricular cavity is fully obliterated on pharmacological stress, that indicates that the possibility of that gentleman to have any CV event is very, very rare. So, in a pharmacological stress test, presence of cavity obliteration, we can safely leave the patient on medical management. No need to send them for CABG or for angioplasty. As I have told, triple tracking is the one which can detect a non-obstructive disease and differentiate CAD versus CAD patients. 3D echo also we have discussed. Now, as I told you, we can do a contrast and estimate the ventricular function. So here you can see with the administration of contrast, you can see the endocardial border nicely. So you can map the endocardial border without much of a trouble. And in a recent trial, by using a contrast stress echo, the sensitivity and specificity of stress echocardiography has increased. So nowadays we have a low threshold to do a contrast echocardiography in ischemic heart disease. Apart from this, apart from ventricular function, we can estimate the myocardial perfusion also. That is what we call as the MCE or myocardial contrast echo with the same contrast. So what happens is when you look at the ventricular function, that is not a cellular thing. It is at a macro level. But if there is a myocardial contrast echo is reduced, that means the cellular dysfunction is there. So with this contrast echo, we can determine whether there is a cellular problem or a macro problem in the heart. Similarly, you can see in this patient a hugely dilated ventricle with mitral regurgitation. We can see ischemic heart disease, about 1/3 of the patients tend to have a functional mitral regurgitation. So also we can see a left ventricle thrombus. You can see here at the apex, you can see a left ventricle thrombus in a patient. You can see this is a layered thrombus, same intensity of that of the endocardial border. Indicates here it's a chronically present thrombus. For example, this ventricular thrombus, this is a ventricular thrombus which is chronic. It's not an acute thrombus. If it is an acute thrombus, you can see of the same intensity of the blood. So if you see a darker thrombus, then it is a fresh thrombus. If you see a echolucent thrombus like this, it is a chronic thrombus. So it's a very interesting way. What is the difference? If it is an acute thrombus, we need to give anticoagulation. But if it is an organized thrombus like this, you don't need to give oral anticoagulation to these patients. Similarly, we can look at the dobutamine stress echo also. We can look at various. Okay, so you can estimate. This is the basal one. You can see the cursor here. You can see the basal one, and at a dose of 10 micrograms, you can see that the ventricle you can see the endocardial border here. Here, endocardial border is decreased. That means you can see that the ventricular contraction is better. But with the higher doses, the ventricular contraction is once again lost. That means here it is low, here it is improved, but here it is further again reduced, indicating that there is a biphasic response. If there is a biphasic response, it indicates after you do a bypass surgery for this patient, the muscle is going to get better. So a biphasic response indicates that there is a myocardial viability recovery is there. If there is no response, then it is a non-viable myocardium. Now, the same thing we can see in a two-chamber view also, the contrast echo. If there is an improvement of at least 4 or beyond segments, you can say that this patient, you do a bypass surgery, is going to get better. Why is it important is, many times we are now getting patients who have got significant left ventricular dysfunction, so much of coronary artery disease. We do a bypass surgery, is the patient going to get better or not? This is a very crucial decision for us. If we are not able to understand that by doing a surgery, you are putting the patient to huge risk. So to avoid that risk, we need to treat these patients in a much better way. I will show here a patient whom we have done an angioplasty recently, about a couple of weeks ago. This patient comes with a significant heart failure for about 7 months duration, and you can see pre-PTCA LV ejection fraction is 28%, and you can see the GLS, lot of white areas are there. And this is 2 days after angioplasty. There is not much of improvement in the ejection fraction, but the global longitudinal strain, you can see that there is a significant improvement, indicating that if you can use this as a parameter for surveillance and as well as a marker of recovery or success of your revascularization procedure. Now, so we have discussed a lot of modalities on echocardiography, a common thing what we do in our day-to-day practice. Now let's go to coronary angiography. That is also very commonly done in our practice. So in a patient, why coronary angiography is very important? We can assess the anatomy, and if we use some advanced modalities, we can have the physiology, and with the physiology, we can risk stratify the patient, and based upon the anatomy, physiology, and risk stratification, we can guide the treatment. What is the best way to revascularize the patient? So by coronary angiography, we can assess the anatomy, physiology, we can risk stratify the patient, as well as plan and perform the further revascularization for these procedures, for these patients. Sorry. Now, there are 2 ways of coronary angiography. We all know. One is a routine invasive coronary angiography. That's what we do in the cath lab, which is the gold standard for anatomical assessment. The advantage when you do a invasive coronary angiography in the cath lab is we can do associated imaging like IVAS, OCT, NIRS, and also we can do a real-time physiology assessment also. So we can do the anatomy, we can characterize the plot, as well as we can have much more anatomical details and also estimate the physiological relevance of this procedure of the lesion in invasive coronary angiography. Whereas we can get the similar information with a CT coronary angiography. The advantage of the CT is very rapid. The patient immediately accepts the procedure. It is non-invasive, very fast, and you get a reasonably good information from the CT coronary angiography. But what is the role of CT coronary angiography versus invasive coronary angiography? CT coronary angiography has got a high negative predictive value. That means if the CT coronary angiography is normal, you can safely exclude that this patient does not have coronary artery disease. So this is a very good negative predictive value test. And nowadays, we have got physiology also integrated into the CT. That is what we call the CT FFR. In the West, it has almost become, CT plus CT FFR has almost replaced coronary angiography as a procedure. So in my practice also last 5-6 months, my threshold to perform angiography is higher, and we have more and more patients going for CT angiography because we know how to interpret them, we can understand it very fast, and we can get much more, sometimes better detail for procedural planning. As I told you, the negative predictive value of CT angiography has been assessed in the accuracy trial, and any lesion more than 50 or 70%, it is impossible to miss with a CT angio. What we call the cath lab coronary angio. So any lesion, it is very easy to find, and compared to the CT scan, the radiation is very low in a cath lab coronary angiography. Now, what is the role of CT coronary angiography in new onset heart failure? This is a study which was published a couple of weeks ago, which showed that if a patient with new onset heart failure, the first test, if you do a CT angiography, if you say that there is no coronary artery disease on CT angiography, you can safely continue them on medication. If there is a disease, then about 50% of them are going for revascularization rest 50% of them remained on medicine. So CT angiography is a good, CT coronary angiography in new onset heart failure is a good investigation, like a gatekeeper for us to say which test we should do for this patient. So CT is becoming a much better test. Now, when we go to the invasive coronary angiography, we do for IVUS, OCT, FFR, and compared to sensitivity, invasive is the gold standard, and specificity is also very high. But for negative predictive value, invasive coronary angiography is not the test, but for negative predictive value, CT coronary angiography is the test. So, in conclusion, coronary CT excludes disease, whereas invasive coronary angiography provides a comprehensive assessment of the coronary artery disease. So, as an initial test, I am doing CT coronary angiography. I think it has got a very good utility and very fast in our patients. Now we have already discussed that why we should do an angiography for these patients. Why we have to do is, if ischemic heart disease, there is a 50% higher mortality in cardiomyopathy with ischemic versus non-ischemic. So any patient who has got an ischemic heart problem with LV dysfunction, they have a much higher mortality. And any coronary artery disease triples the mortality risk. And if you do an angiography early, you are going to reduce the mortality and readmissions. So these are very, very powerful statements, very simply, you might consider them simple, but I see in my practice, a lot of times cardiologists are also, when there is an LV dysfunction, they feel that the angiography sometimes gets missed out. So angiography is a fundamental test in heart failure. So that is very important for us to understand. Now, by doing a angiography, there was a study which is known as the Stitch trial. In this Stitch trial, what they did is they took patients with left ventricular dysfunction and they assessed the viability by SPECT. That is a nuclear modality, we'll discuss it later. So by SPECT, we assess the left ventricular function and left ventricular viability. And if it is viable, they did a bypass surgery. And this Stitch trial was negative at the end of 5 years, and at the end of 10 years, there is certain degree of benefit which is shown with the Stitch trial. So those patients who underwent bypass surgery, followed up for 10 years, they had a better outcome. So who are the patients who had a better outcome in the Stitch trial? Those patients with triple vessel disease, proximal LAD stenosis, and left main disease, even though they are excluded in this trial, they carry a highest risk. So triple vessel disease, proximal LAD stenosis, these groups of patients, if you revascularize them, those are the patients who are going to get better. So whenever you have a patient of proximal LAD or TVD, if there is LV dysfunction, do not hesitate to do a further viability assessment and consider whether they benefited or not. So let us look at, once by identifying whether the patient has got CAD or not, if the patient has got multivessel disease, left vein, proximal LAD, and FFR positive, those are the groups of patients. If we do a revascularization after these things, they are going to get better. So what is the algorithm? Patient comes to us with heart failure. You consider that this patient might be having heart failure with low ejection fraction, and you consider that there is a high risk of CAD, high pretest probability of CAD. That means patient has got diabetes, hypertension, previous myocardial infarction, regional warm abnormality. If they are there, then there is a high pretest probability of CAD. In those cases, you can go for a conventional angiography. You can say that whether there is CAD or no CAD. If there is no CAD, they go for a medical management. But if there is a CAD which is high grade, then they go for an invasive coronary angiography. That means the first test is a CT angio, and if there is an obstructive CAD, they go for an invasive angio. And on invasive angio, if there is a low risk CAD, low risk means absence of left main, absence of proximal left LAD, absence of triple vessel disease, and FFR lesion. That is the low risk CAD, you can safely put them on medicines. If there is any of these high risk features are there, they should go for a CABG. So this is the algorithm for us to dictate whether this patient requires angioplasty or surgery. So Diagnostic strategy, CT coronary angiography has excellent negative predictive value. Invasive coronary angiography has got a better prediction of anatomic burden. Treatment selection, most of the patients with LV dysfunction and heart failure, they benefit from CABG, not with PCI. So that is a very important thing we need to understand. And FFR positive means it remains a gold standard for intervention decisions. And it's a very cost-effective strategy. For example, if you do a CT coronary angiography, if it is normal, you don't need to go for an invasive angiography, or you don't need to go for a further investigation of these patients on the coronary aspect. Now we have discussed about echo, we have discussed about CT. Now we are going to the other advanced modality, there is a cardiac PET. So whenever you have a cardiac PET, that gives a molecular imaging. Coronary is epicardial, whereas PET gives a molecular imaging. Previously, we used to do a SPECT. SPECT means with a gamma camera. PET means with a PET CT scan. So PET is the contemporary way. SPECT has got low sensitivity and low specificity. So if we do a SPECT, you underdiagnose and undertreat many patients. So that was what was my experience for many years. So SPECT did not give me a very good support for me for decision making. Whereas with the PET, you can make a very beautiful diagnostic and decision making platform. SPECT has got better spatial resolution. It gives a myocardial blood flow also, and the SPECT has got reduced radiation exposure. So PET is the way how we assess the myocardial viability in the current day. So there are multiple radio tracers, but what we do is a FDG PET. So the half-life is around 2 hours, and it indicates the metabolism, and also it indicates the presence of inflammation. We have got some other 13N ammonia which is not there, but it can use the myocardial blood flow. So 13 ammonia for myocardial blood flow, FDG PET for myocardial metabolism. If you have, right now we do not have a 13 ammonia in our centers because we do not have a cyclotron. But if there is a cyclotron, we can use the 13N ammonia in our day-to-day practice, so that we will be able to identify myocardial blood flow. That means you can say whether by doing an angioplasty, you can say, oh, the blood flow to the heart is improved, but it might not improve the cellular metabolism. So if you have got a 13 ammonia positive improvement in blood flow, that means the heart is going to recover. With an FDG PET, you can assess the metabolism, but you cannot assess the myocardial blood flow. So that is the limitation. Now, let us look at the ischemic cardiomyopathy. For this stress thallium, that is the specter, is useful for epicardial stress, epicardial coronary artery detection. So SPECT is with gamma camera, PET is with CT scan. So I just wanted to, because they are very closely mimicking names, so I just wanted to clarify them. SPECT is with gamma, and this is with the PET is with the CT scan. So SPECT is useful for epicardial coronary flow. It has got 85% sensitivity and specificity, and it has got a high negative predictive value. For example, many of us who do not have symptoms, if you want to certainly rule out, one way is to do a CT coronary angiography, which gives you an epicardial anatomical information. If you want a cellular physiological information, you can do a SPECT to rule out unnecessary catheterization. So you don't want to do an angiography. But nowadays, as I told you, the pendulum has moved far away from SPECT. It is predominantly now a PET-CT guided assessment of the ventricular function. So what is this important? This is a study which was published in 2023. This is a very interesting study. For example, you have a patient with coronary artery disease. You do an angiography for the patient. The coronary lesion is sometimes important, sometimes less important. But after the coronary lesion is detected, then what they do is they subjected this patient for a PET-CT. So this PET-CT can be ischemic response or a non-ischemic response. So those patients who had a non-ischemic PET-CT response, they just left on medical management. Whereas those patients who have got an ischemic PET-CT, they underwent a revascularization, either CABG or PTCA. So after that, when they followed up these patients for 5 years, it has been shown that those patients who undergone angioplasty or bypass, those patients who are just managed on medicines, if the PET-CT is negative, the event rates are the same in both the groups. That indicates that PET-CT is a very good predictor to guide whether a revascularization is required or not. So nowadays we have to see doing a PTCA, doing a CABG, or if you ask me, they are quite easy. But taking a decision whether the patient requires a or the patient is going to benefit, whether the patient requires, whether the patient is going to benefit from the procedure is the most important decision which we need to see. So now let us say if there is a, if you can see the orange one, this is the rest perfusion scan. You can see that the perfusion is good, and here the metabolism is also good. So both perfusion and metabolism are in the same color. That indicates there is no, there is a viable myocardium and there is no ischemia. So that means there is no muscle damage for this patient. So perfusion and metabolism both are matched, then it indicates a viable myocardium. If there is a perfusion and metabolism, you can see that the perfusion is reduced, the perfusion is the metabolism. If there is mismatch is there, if there are, sorry, apology. If the both are absent, like what you can see in another patient, you can see here, both perfusion is reduced, scar is also there, sorry, apologies. If the perfusion is reduced and the scar is also there, that means the metabolism is also not there, perfusion is not there, metabolism is not there, then it indicates it is non-viable. Whereas here, perfusion is good, metabolism is good, then it is once again a viable. If both are not there, then it is a non-viable type of a myocardium. So you have to see how whether the perfusion and the metabolism are matched or mismatched. Based upon that, we can say whether the person is having recoverable or non-recoverable on the FDG PET. Now, what is the advantage of doing this FDG PET? How does it reflect into the practices? In the Stitch trial, as I told you, they did the SPECT imaging and they found no benefit of assessing viability. That is one of the major limitations of the Stitch trial, because it's a long ago trial, about 15 years ago trial. So the Stitch trial did not have the advantage of doing a PET-CT, but the contemporary trials which used the PET-CT has given a much more clearer answer. There is one more trial which is called the PCI in viable myocardium using the Revivo trial. This also did not show mortality benefit. It used both PET and SPECT. So we have to understand that there are limitations of SPECT. PET is a better modality, and PET, if it is adhered to, we have seen in the Century trial that there is a significant predictability of your revascularization efficacy. And you do PET-guided interventions that can result in 30% mortality reduction. We can also assess the myocardial flow rhythm, as I told you, with the 13 ammonia as a radio marker, radio tracer for the testing. Now, other thing is, whenever we do these patients, you cannot say whether this patient has got an ischemic cardiomyopathy or non-ischemic. It's extremely difficult. I had one patient, I should have included it. One patient gets a, this boy is 27-year-old and he had chest pain. He was in Rishikesh. He goes to Rishikesh AIMS. They do an angiography for him. The coronary angio is normal. They label him as non-ST elevation myocardial infarction. Before doing the coronary angiography, they did the troponins, which were around 3,000 to 4,000 numbers. So with that 4,000 troponin and the coronary angiography is normal, he comes to me. Then I did a complete workup for him. We did a cardiac MRI, and cardiac MRI was suggestive of an inflammatory cardiomyopathy. Then we did a PET-CT, and it showed that it is a cardiac sarcoidosis, isolated cardiac sarcoidosis. So it is very, very common to think which was an ischemic at AIMS. They labeled it as ischemic, but it is not ischemic. It is a non-ischemic. So ischemic means you have to give aspirin, clopidogrel, statin, and all those things. Non-ischemic inflammatory means you should give steroid and some other stuff. So you have to understand what is the anatomy, what is the etiology of the LV dysfunction. So with a cardiac sarcoidosis, which is a very common entity, nowadays I think I would be picking about 3 to 4 cases of cardiac sarcoidosis in a month. So this is a very common entity. If you start investigating further, you will be finding these entities in our day-to-day practice. And then I would show you some cardiac sarcoid images, and we can see a cardiac amyloid also, where we do a technetium pyrovascular scan to understand where there is an intense myocardial uptake and there is a suppression of uptake in the rest of the tissues in the chest. So there is an intense myocardial uptake of the PYP scan, so cardiac amyloidosis. Cardiac amyloidosis is a very common problem, especially in the elderly people. So we should suspect any patient with heart failure with preserved ejection fraction in an elderly patient, a PYP scan to diagnose a cardiac amyloid, which is also quite common. Similarly, myocarditis is also, as I told you, I was just telling you, myocarditis either due to sarcoid or viral, whatever it is, we can do a MR and a PET CT to identify the presence of cardiac sarcoidosis. So we had discussed about the role of nuclear testing in diagnosing ischemic, non-ischemic, and in ischemic viable versus non-viable, and the role of PET CT as a superior modality compared to that of a SPECT. Now let us integrate the data. We studied about PET, we studied about echo, we studied about cardiac MRI, and we studied about coronary angiography. So we studied multiple modalities of assessing the coronary artery disease. Now let's look at it. How do you take all this information and come to a superior decision making? So integrating all these modalities to come. So there are three types of myocardial dysfunction. One is a completely scarred myocardium, which you have seen. Sometimes with a reduced supply, the myocardium reduces its demand. So that is what we call as the hibernating myocardium. Stunned myocardium is if there is an insult, the adjacent area becomes stunned. Like in a movie, when a villain hits the one fellow, the rest of the people become stunned. Like that, the myocardium also, the adjacent to the ischemic area gets stunned. So that is what we call as the stunned myocardium. Hibernating means in a reduced supply of blood supply, you tend to reduce, the myocardium tends to reduce the needs. Like you don't have much, you try to cut down your expenses. Similarly, the myocardium reduces its expenses in the light of reduced blood supply, that is hibernating. But you do not have a clear-cut entity of one is hibernation, one is stunning. There is always a continuum. A stunning can become a hibernating, and hibernating can become a stunned myocardium. So there can be different ways, and both can go into a myocardial scar also. And stunning improves with is present. The myocardial blood flow improves with exercise, stress, and this happens within few hours to days, whereas hibernation happens over weeks to months, as the term indicates, and scar happens immediately or within the first few weeks. So you can have three different types of myocardial damage: hibernation, stunning, and a scar. This is non-recoverable. These two are recoverable. So we are going to focus on these two entities in the next few slides. So we can assess the myocardial recovery by multiple ways: thallium, technetium, FDG PET, MRI, dobutamine MRI, dobutamine echo. So multiple ways. If you see, the highest sensitivity is with late gadolinium enhancement. If there is a late gadolinium enhancement, usually it indicates the myocardium is gone. Whereas the dobutamine stress echo, if stress CMR, if it is positive, that means there is a recovery with dobutamine stress CMR or cardiac MRI, it indicates that the myocardium has got a higher chance of recovery. So you have got multiple modalities with the different possibilities of recovery. Now let us look at it. If you look at the entire myocardium, for estimating the contraction, we can do a dobutamine echo or dobutamine MRI. For estimating the metabolism, we can do an FDG PET. We have just now seen the previous image. With an FDG PET, we can see the metabolism. If you want to see the mitochondrial intactness, you can do a SPECT. But if you want to see the cell membrane integrity, you can do an MRI or a SPECT with thallium. So different modalities give different information, and based upon that information, we can say whether the patient can recover, whether the patient has got a high risk MI, whether the patient has got a heterogeneous outcome. So there are a lot of trials, as I told you, which showed varying outcomes for these patients. Now, when do we use this viability testing is you cannot rely upon one modality, we have to do a multi-modality. We can assess the risk, how it risk can vary and how you can go forward. Apart from that, we can do an NT-proBNP, which is a very good marker for us to say whether the person has got a higher myocardial damage, or sometimes there is a metabolic personal risk profiling also we can do, which is not available right now. But NT-proBNP inflammatory markers give us an indication that this patient has got an aggressive heart failure or a less aggressive heart failure. I will show you one more patient who presents to us with a history of anti-rheumatoid, elevated troponin, elevated proBNP, coronary angiography done, triple vessel disease, and he has been sent to us for carriage. So let me, So if you can see here that there is a significant disease in the left main and significant disease in the LAD, and the ventricle is hardly contracting. The right corner, I thought that this patient has got a significant ventricular dysfunction and we need to treat him. So we went on and assessed the myocardium because he had a MI recently. You can see on T2 imaging, you can see the myocardial edema. But when you see after the contrast, there is no white patchy opacity. That means on contrast, there is no late gadolinium enhancement. So you can see only edema and MRI doesn't show LGE. I thought that, oh, this patient has got only myocardial edema. So I can possibly revascularize this patient because he has got a high risk coronary anatomy. So what I did was I sent him for a FDG PET. Here you can see that the perfusion is not there. That means usually the blue is the perfusion, but here it is becoming red. And here the metabolism has become predominantly blue. That means the metabolism is not there. So only some small area, the metabolism is preserved. Here also it is red, but it is not pure red. So indicating here also metabolism is lost. Here also metabolism, whole area metabolism is lost, and the perfusion is also lost. So perfusion is lost, metabolism is lost. So it is a scarred myocardium. Then we did a cardiac doppler stress echo, and I was showing you these images. You can see that there is some improvement in this area, but this improvement is lost at higher doses. So initially, I was thinking that this patient could get better. But what is important is when you went back and did this scar on the FDG PET, the reduced perfusion, no metabolism, indicate there is a scar. And if there is a scar, you do a CABG, that person is not going to come off the table. So it's very important you assess by multimodality. You have to talk with a nuclear physician, you have to talk with your radiologist, you have to talk with yourself, because what is the anatomy, is the patient going to get better? So, and you have to talk with your surgeon. So with all these things only we can come to a clear-cut plan of management. So now you have a patient who has got coronary artery disease, who has got heart failure. So how do you manage them? You can always assess for the risk factors for atherosclerosis, and physical exam might not be enough, but ECG might show you that there is a ischemia. Once after that, you can do a coronary angio, stress echo, stress CMR, and PET CT to identify what is the extent of the coronary artery disease for this patient. So your multimodality imaging is essential for us to look at these patients. After you establish it is a coronary artery disease, as we have discussed in our first edition of the heart failure clinics, guideline-directed medical therapy is the cornerstone of heart failure management. ACE inhibitor, ARNI, beta blocker, MRA, SGLT2 inhibitor. These 4 groups of drugs you cannot afford not to give to any patient. You should give for all patients these 4 groups of drugs, without which the patients will not do better. There are various ways how you can give this medication. You can give them sequentially one after another, but nowadays what we do is we give them rapid, fast, and most of the time simultaneous. That means we give all the 4 drugs if the patient is hemodynamically stable, and if you treat 4 patients, 1 death is preserved in the first 2 years. So you've got a substantial early mortality reduction if you give 4 guideline-directed medical therapy. Now, what are the other advantages with the SGLT2 inhibitors? You can see that there is a weight reduction, there is a reduction of heart failure and a reduction of CV mortality. So SGLT2 inhibitor, EMPA, DAPA are must for all patients with heart failure. Similarly, one more drug which is very important for our heart failure patients, especially those with preserved ejection fraction, that means with normal EF and obese group of people, is GLP-1 receptor agonist. So that is what is the most famous drugs in the last 2 years. That is the GLP-1 receptor agonist. Those are the semaglutide and the GLP-1 and GAP. That is the Mounjaro. That is the tirzepatide. So tirzepatide and semaglutide, these two are the GLP-1 receptor agonists which I use in my daily practice, and these have reduced, especially with preserved ejection fraction, they have reduced the CV event by 20%. And it is always best if you combine both GLP-1 as well as SGLT2. Combination of these two can reduce the mortality by 30% compared to each drug alone. So always combine GLP-1 RA with an SGLT2 in our day-to-day practice. You have got some other new drugs which have been introduced in the last 2 years. Versiquat is one of those drugs. Omecamtiv mecarbil is another drug which has been approved by the FDA last year. But these drugs have got mixed results. They are not as strong as the guideline-directed medical therapy and are not as strong as the GLP-1 receptor agonists. Now let's go on to a very common entity in our day-to-day practice: obesity complicating heart failure. We all know what are the cutoff points for obesity. The Asians, we give the much lower cutoff points to say that the person is obese. Patients with obesity and heart failure, twofold higher mortality increase. How do we treat them? We can treat them with SGLT2 inhibitors. You can see here SGLT2 inhibitors in a large meta-analysis of about 15,000 patients, and in the emperor-reduced patients reduces the CV mortality across various spectrum of body mass index. So SGLT2 inhibitor for obesity-induced heart failure is a must for all the patients. Beyond that, we can give for HFpEF patients semaglutide for these patients, and these drugs can reduce the weight by about 5 to 10%, and that is what we can get with a caloric restriction and other specialized diets. We can further benefit what we have already achieved, and along with the supervised exercise programs, and as I was telling you already, combination of SGLT2 and GLP-1. Now that brings us to one more question. Our surgical colleagues want to understand whether they can do bariatric surgery for heart failure patients. Bariatric surgery you have got for people who have got more than 35 BMI, and that reduces the weight by about 30% and 40% reduction in CV event rates, and improvement of ejection fraction and reduced symptoms is one of the benefits of doing bariatric surgery. Whenever we are doing by sending a patient for bariatric surgery, we should suggest them a sleeve gastrectomy instead of a gastric bypass. So a sleeve gastrectomy is a better treatment because these are high-risk cardiac patients, and we need to perioperatively as well as preoperatively prepare them. And compared to GLP-1 receptor agonist, bariatric surgery has been shown to have a much better outcome for these patients. But as you know, it is an invasive procedure. So what are we going to see in this year and next year is tirzepatide in combination with the SGLT2 inhibitor, and possibly for very high risk and very resistant people, then possibly bariatric surgery. We will be, nowadays we do a lot of genetic markers for heart failure. So for genetic markers also helps us to understand what is the etiology of heart failure, but that is predominantly in a non-ischemic, so we are not going to discuss today on this one. Now, what is the revascularization strategy? For example, any patient with coronary artery disease and ventricular dysfunction, if chest pain is the presentation, this is very important. If chest pain is the presentation, don't wait. Revascularize the patient, either by angioplasty or bypass surgery. If the patient has got triple vessel disease, left main, go for bypass surgery. If it's single vessel disease or two vessel disease, you go for a angioplasty. So, angina is the presentation, go for revascularization. If heart failure is the presentation, then you have to further work up guideline-directed medical therapy. If there is a severe triple vessel disease in left main, then he will go for a surgical thing. Otherwise, stabilization of medicines, and if a high-risk anatomy only, you will go for a CABG. Now, two different studies, as I told you, STITCH trial and REVIVE trial. REVIVE is a British trial. and it did not show a benefit of angioplasty in heart failure. Stitch trial at the end of 5 years did not show any benefit of CABG in heart failure, but beyond 5 years, at the end of 10 years, it showed some degree of improvement in bypass surgery in LV dysfunction patients. So possibly the bottom line is heart failure with triple vessel disease and left main, those patients should go for a bypass. Now, if the patient has got severe MRO, this is also one more very important thing. Patient has got some mitral regurgitation, cardiologist suggests them a mitral valve replacement. Please, no mitral valve replacement if it is mild or moderate MR. Only if there is a severe MR and if it is not getting better, then we should go for a CABG plus a valve replacement. Otherwise, you do a valve replacement, this patient is not going to do well because you are going to increase the mitral inflow obstruction, because a new valve you might think it is good, but the new valve, the size is much smaller compared to a natural valve. And there are certain studies, certain ways in which we used to remove the infarcted and aneurysmal myocardium and put a patch and do the surgery for the nowadays. About 10 years ago we used to do, but nowadays surgical ventricular restoration is not recommended. So no MR surgery unless it is severe MR. Ventricular restoration is not a very good, did not show a very good benefit for these patients. Now, the final thing what we are going to discuss is about the arrhythmic risk. So we have discussed about the heart failure risk. Many times you treat the heart failure, the patient dies due to sudden cardiac death. It will be, the family will not accept it. So after revascularization also you should understand what is the risk of sudden death. Sudden death is defined as a death due to a cardiac cause within 1 hour of symptom onset, and most commonly it is due to arrhythmia. And two settings. One is in an acute MI, patient develops sudden cardiac death, that is due to ventricular fibrillation. Here ischemia is the cause. So ventricular fibrillation, early in an acute MI, treat the coronary artery block. If the ventricular fibrillation is after a few weeks, at least 5 to 7 days after the myocardial infarction, that is due to scar, and for this you have to consider a cardiac implantable electronic device, CIED. So that is the ICD or a CRTD. So those patients who have got a persistent ventricular dysfunction, higher NYHA class, ventricular ectopy, those are the group of patients who are going to have very high event rates. Now somebody might ask me, okay, patient has got arrhythmia, underlying coronary artery disease, why can't I give medicines? The medication, when they tried for these patients in acute ischemic heart disease like amiodarone, all those things, they did not show any benefit. So prophylactic amiodarone for preventing sudden death has got no role. Similarly, if a patient had a ventricular fibrillation, after the ventricular fibrillation you viewed as a secondary prevention strategy also, amiodarone did not have any role. So antiarrhythmic drugs did not show a primary prevention role nor a secondary prevention role. And most importantly, they were found to be actually harmful and increased the mortality rate. So please don't give antiarrhythmic drugs for a longer time in these patients, either for a primary prevention or a secondary prevention. Do not give amidarones and all those things. The only way how you can prevent the sudden cardiac death is defibrillator. But at the same time, now you have got very good guideline-directed medical therapy. Most of our patients with the EF of 30%, for the next 3 to 6 months, the EF improves to about 40-45%. So the risk of sudden cardiac death is tremendously reduced. You have got multiple therapies. You have got a transvenous ICD, CRTD. You have got a subcutaneous ICD. You have got a cardiac contractility modulation device. You have got a left bundle branch pacing to improve the ventricular function and baroreflex activation therapy. So you have got multiple cardiac implantable electronic devices to improve the cardiac function. And there are a lot of studies which have been done in this setting. One is with the primary prevention, MADIT, MADIT2, and STAT-F, which has been shown that EF less than 35% has been shown to have an improvement when you put a ICD therapy. But this is mostly useful when the patient is class 2. That means EF less than 35% and the patient has to get this procedure done early, not for a class 3 or class 4 patient where the mortality will not be so radically reduced. Similarly, for secondary prevention also, ICD has been shown to be a very good therapy. These are the trials which have been published about 20-25 years ago, showing that they have been outcome. Similarly, for cardiac resynchronization therapy also, we have got multiple trials saying that for those patients with left bundle branch block and a QRS more than 150 milliseconds, a CRTD might be a good therapy. The other day, I had one of my patients who underwent a cabbage. His daughter-in-law is an electrophysiologist in the USA. She was asking me, sir, you put for my father-in-law a bileaf pacing with a CRTD. That means the threshold for putting an ICD in a patient who has got a persistent ventricular dysfunction and a high-risk cardiac anatomy is getting more and more. And as a conclusion, I will give you, for those patients who have got heart failure, it could be either ischemic in about 60% of the cases and non-ischemic in about 40% of the cases. We need to do a multimodality imaging, echo, cardiac MR, CT angiography. Then you have to do a PET CT, you have to do an angiography. And based upon these things, you should give guideline-directed medical therapy of these 4 pillars. And along with the 4 pillars, after the 4 pillars, if the left ventricular function still continues to be depressed, then you can do an ICD or you can do a left bundle placing, angioplasty, or a bypass surgery. So you have got intervention, coronary interventions, and you have got electrical intervention, heart failure. So that gives you a very good outcomes for our patients. I think I will stop here and take some questions from you because ischemia, viability assessment, what are the medical therapies and how do you integrate all these multiple modalities in our practice is something which we should adopt given the complexity of the patient what we are seeing nowadays. Thank you all.
Sir.
Yes, sir.
Sir, it's a very exhaustive topic, but very understandable voice. All the time you do the same thing. Sir, actually, cases in our OPs, a person who had myocardial infarction about 5 years back with his scar at the apex had LED, proximal LED, and CT angio has given him little proliferation and obstruction rate is around 50, something like that. But echocardiogram and all we put results of 60-65%.
Yeah, it's not.
Yes. So for this patient is going well. So because already there is a scar, like you said, the function, dysfunction, contractility, any problem. So how to keep the patient follow up at your place?
So obviously, the recovery must have happened with guideline-directed therapy. So GDMD have to be continued, the 4 pillars, along with antiplatelets, good statins. That is the fundamental of foundational medical management. Double statin therapy, single antiplatelet drugs, and as a double lipid-lowering therapy, statin and non-statin therapy together, and antiplatelet, and 4 pillars of heart failure. Even though the ventricle recovers, we should continue these medications for lifelong. And what is the you maintain your low the patient's LDL and HbA1c and blood pressure low, the risk of recurrence of event is significantly reduced.
In case some of my patients are not tolerating this, you are telling double statin, this and that. But any alternative for this? Because statin is the anchor of the practice. So for these people, how to manage?
So now, actually, I think we have to, if the patient is not tolerating, the ways are you can substitute a particular statin with another statin, or start slow, start with a lower dose and step up the dose, or nowadays you have got a combination of non-statin therapy like bempedoic acid plus ischemic combination, or if the patient can afford, you can give along with a small dose of statin and these drugs, you can give a PCSK9 inhibitor or monoclonal antibodies like inclisiran. So you have got multiple therapeutic options for lipid lowering nowadays. So wonderful options we have. So we'll be able to get them low as much as possible.
They're lifelong.
They are lifelong, certainly lifelong.
Right, sir. You said about that PET echo.
PET CT.
PET PET echo.
No, PET CT, sir.
Echocardiogram. PET CT.
PET CT.
PET CT. Taking echocardiogram.
No, that gives you the 17 segment model, and you can say whether the ventricular dysfunction is good or not.
It's visible or
Or it is a scar by multiple.
All these things are doing here.
Yes, certainly.
What's the cost of this?
16,000 rupees.
16,000 rupees. Thank you, sir. Thank you very much.
Thank you.
Sir, in last years, 4 pillars. GLP-2 inhibitors is best or GLP-1 or GIP?
No, heart failure with reduced ejection fraction, we do not have data about GLP-1. GLP-1 is only for preserved ejection fraction. For reduced ejection fraction, SGLT2 inhibitor only. For preserved ejection fraction, you can give SGLT2 inhibitor and GLP-1 receptor agonist. Both we can.
No, GLP-1 or GAP will reduce adiponectin.
Yes.
If it is adiponectin is low, automatically lipid metabolism, cardiac metabolism will go down. How to manage this? Because fat loss is 80% of the fat loss.
So they have to, it is not enough for them to do only medication. Along with that, it's very important for them to maintain their muscle mass for them to preserve it. So they should always, all these measures should be combined with resistance training. Otherwise, they will not do that. So resistance training with these molecules. So we always encourage our heart failure patients when we put them on a GLP-1 RA, we encourage them to do isometric exercises and very weightlifting and high protein intake. So that is very important for them to maintain the muscle.
Usually lean mass it's very difficult to regain.
Regain, yes.
Regain.
But with these people are chronically deconditioned. So if we make them do some isometric exercise or resistance training, usually they get better enough for them to do good. Yeah. Thank you.
Thank you, sir. Thank you very much for such a wonderful talk on heart failure. And I request Sadhana Madam to felicitate Dr. Raghu, sir. Please, sir. Thank you very much, Doctor. Now I request delegates to proceed for the dinner. Thank you.